So today is the first lecture of the functional urology. So we will start with the history and the assessment of the lower urinary tract symptoms. So Dr. Mohibullah is going to give a talk on evolution of lower urinary tract symptoms, uroflowmetry, and the widening diary of the patient. Dr. Mohibullah, start.
Assalamu alaikum everyone. So today is my topic on the evaluation of lower urinary tract symptoms, and the moderator is Dr. Riyaz Hussain Lagari. So my topic outline is the history based on an examination, bladder diary, uroflowmetry, and post-void volume. Lower urinary tract is composed of the bladder and urethra, and the two defining functions of the lower urinary tract are the urinary storage and bladder emptying. The lower urinary tract depends on the function of many components, including central nervous system, peripheral, bladder smooth muscle, bladder stoma, urethral muscle, pelvic floor muscle, and the external urethral sphincter. The maturation cycle is divided into two phases: the bladder filling or storage phases, or the bladder emptying voiding phases. The bladder filling phases require the accommodation of increasing volume of urine at a low detrusal pressure, a bladder outlet that is closed at rest, absence of involuntary bladder contractions. The bladder emptying requires the contraction of the bladder smooth muscle and lowering of resistance at the level of the sphincter, absence of aortic obstruction like stricture or the enlarged prostate. So this one is a picture which shows the different causes of the bladder obstruction. LUTs due to overactive bladder, bladder cancers, cystitis, bladder stone, or neurogenic bladder. In prostate, that is prostatic enlargement, prostatic cancer, prostatitis, in urethral stricture, and STD. Or other causes are the constipation, excessive urine output due to diuresis, diabetic mellitus, and the congestive heart failure. So now we come to the symptoms of the lower urinary tract. So lower urinary tract, first symptom is the urinary frequency, which is the need to urinate many times during the day. Urinary frequency is distinguished from polyuria, which is urine output of more than 3 liters per day. The normal number of times to urinate per day is between 6 to 7 times in a 24-hour period. Some studies show it is 5 to 6 and some to 6 to 7, or some studies show 7 to 8. So the average is 6 to 7 in a 24 hours according to EUA. The causes of the urinary frequency are the lifestyle, including drinking a lot of fluids, medical conditions such as diabetic mellitus, diabetic encephalitis, pregnancy, and prostate gland, anxiety, diuretics, stroke, and other brain or nervous system, urinary tract infection, sexual transmitted disease, and tumor or masses in the pelvic area. Other causes are the interstitial cystitis, a type of inflammation of the bladder wall, overactive bladder, bladder cancer, stone of the kidneys and bladder, urinary incontinence, urinary urethral stricture, radiation of the pelvis, and colon diverticulitis. So nocturia is defined as a walking because of the desire to void during intense sleep, can be the result of any abnormality in urinary tract or the underlying medical conditions. Voiding that is preceded and followed by sleep. For 2/3 of men and women over 70 urinate at least once per night, which is a normal phenomena. The study shows that it is very common for most people to wake up once at night. Nocturia affect the quality and quantity of life, which shows the individual 70 years or older with nocturia greater risk of skeletal fracture and even death. Risk increase with diabetes, coronary disease, renal disease, and stroke, and sleep efficiency, sleep latency also is rated with increased mortality. Patients taking sleep medicine and diuretic are also at a higher risk of the mortality. The other causes of the nocturia is the lifestyle habits like drinking too much fluids during bedtime, behavioral pattern of the urine, and timing and dose of the medications, sleep disorder like insomnia or sleep apnea. Health conditions, diabetic, high blood pressure, heart diseases, vascular diseases, bladder obstruction due to stone or inflammation, or other previous bladder surgery, overactive bladder symptom, and prostate obstructions. In female, there are vaginal prolapse, menopause, childbirth, pelvic prolapse, and in male, enlarged prostate or the causes of the nocturia. Other are the edema in the lower limbs, interstitial cystitis, and poor bladder, reduced bladder capacity. Polyuria, when your body makes too much urine in 24 hours period. Urine output of greater than 3 liters per day is a polyuria. Nocturnal polyuria, when your body makes too much urine during the night. Study shows that the nocturnal volume, 20 to 30% of total 24 hours volume is defined as nocturnal polyuria. The bladder storage problems, when your bladder doesn't store or release well urine. And mixed nocturia, when more than one of these problems are happening. Urinary urgency is the sudden urge to urinate is due to involuntary contraction of the bladder muscles and is the one of the hallmark of the UTI. Causes of the urinary urgency are the overactive bladder and too much liquids like alcohol, caffeine, and diuretics, interstitial cystitis, vaginal infection, prostatic, enlarged prostate, and side effect of certain medications, disease that affect the nerve endings like multiple sclerosis, diabetic, and damage during childbirth or surgery, pressure on the stomach due to obesity or the pregnancy. Dysuria is a painful urination that is usually pressure on the stomach, DTD. Dysuria is a painful urination that is usually caused by inflammation. Pain usually not felt over the bladder, but is commonly referred to the urethral meatus. Pain occurring at the start of the urination indicates urethral pathology, and we are at the end of the maturation is the bladder origin. Dysuria is frequently accompanied by frequency and urgency. Intermittency is described a urinary stream that is not continuous, complaint of urinary flow that stops and starts one or more occasions during one voiding episode. Another is post-maturation leakage or dribbling. And this condition evokes complaint of involuntary leakage of urine following the complaint of maturation and occur after the patient dressed himself or usually after he left the toilet. Hesitancy is defined as the trouble to start to urinate or maintaining urine flow. It can occur in men and women at any age, but is most common in older men. Causes are the bladder muscle disorder, nerve damage, past surgery, infection, psychological issues, surgery, medication, and cancer, tumor obstructing the urethra or urinary bladder. Urine incontinence is the leakage of urine. It means a person urinate when they do not want to. Control over the urinary sphincter is either lost or weakened and is more common in female, and it is subdivided into 4 general types. Stress incontinence, which is also called is activity-related incontinence, and is most common type of urinary incontinence caused by the strain on the bladder, like jumping, bending, lifting exercise, and even coughing or sneezing. Overweight can also strain the bladder. The weak pelvic floor muscle is another cause. The stress urinary incontinence occur when the intra-abdominal pressure exceeds than the intraurethral pressure. Stress incontinence is more likely in women, and in more men it mostly occur after the prostatectomy. Urinary urgency is the complaint of any involuntary leakage of urine accompanied by or immediate preceded by urgency. It's also known as urge or urged incontinence, and this condition causes the bladder muscle to contract and signal a need to urinate even the bladder is empty. Urge to urinate immediately and may cause accident if you don't make it to the restroom in time. It's a part of the overactive bladder syndrome, and 90% of men who experience the urge urinary incontinence will have detrusor overactivity. Urge incontinence can be caused by physical problems like damage to the spine, brain, or nervous system, and between the spine and the bladder. It can also cause a bladder infection. So overflow incontinence is the another type of the urinary incontinence in which the body makes more urine than the bladder can hold. This may also occur if the bladder is full and can't empty, which causes it to leak. Bladder muscle may not squeeze as it should. Overflow incontinence causes frequent urinating in small amount and constant dribbling. This type is more common in men and is often associated with past prostatectasia or prostatic problems. Mixed incontinence is the complaint of involuntary leakage associated with urgency and also with exertion, effort, sneezing, or coughing. Those with mixed urinary incontinence experience both the stress urinary incontinence and the urgency urinary incontinence. Condition is uncommon in men, and although it may occur after the prostatectomy. Functional incontinence occurs when other disease or disabilities like arthritis or dementia make it difficult to get to the toilet because of the any accidents. Nocturnal enuresis is the involuntary loss of urine that occur during sleep. Nocturnal enuresis is estimated the prevalence of nearly 10% in children aged 70 years. However, in 2 to 3% of children, it may persist in adulthood. The nocturnal enuresis may also manifest later in life and is important symptoms, especially in men, as it may indicate that these men are in higher pressure chronic urinary retention, which is usually associated with upper tract dilation and the risk of the renal failure. The postural incontinence is the voluntary loss of urine associated with change of position from rising or sitting lying position. The continuous urinary incontinence is the complaint of continuous involuntary loss of urine. It's a rare symptom and only exists when there is any fistula. Insensible incontinence is the urinary incontinence in which the patient is unaware of any urine pass and how it is occur. Overall, the causes of the urinary incontinence are in female, the pregnancy, childbirth, urinary tract infection, vaginal infection, weak pelvic floor muscle, and overactive bladder muscles. Obesity, nerve damage, enlarged prostate, prostatic infection, pelvic organ prolapse, and past history of the prostatectomy and hysterectomy are the other causes. This one is the IPSS score to assess the lower urinary tract symptoms, and which its score number is up to 5. If there is no symptoms, which mark is 0. If less than 1 time in 5, it's mark 1. If less than half, it mark 2. About half the time, it mark 3. More than half the time, it's 4, and almost always it's 5. This is the for complete over the past 1 month, in which 7 symptoms are included. That is incomplete emptying, bladder emptying, frequency, intermittency, urgency and weak stream, straining, and nocturia. The IPSS score 0 to 7 shows the mild, and 8 to 19 is moderate, and severe is from 20 to 35. The past medical and surgical history also depend on the lower urinary tract symptoms, which can affect the urinary tract function. The childhood and adult urological history should be obtained. The neurological conditions such as Parkinson's disease, multiple sclerosis, stroke, and spinal injury, back injuries can have considerable impact on lower urinary tract function. Medical diagnosis such as diabetic mellitus, dementia can also affect mostly on the continence. Radiation therapy or past trauma to neurological or urological, which can affect the lower urinary function, especially with regard to outlet resistance or bladder contractibility and stability. In past medical history of the women, the gynecological and obstetric history is compulsory, in which including gravity, parity, and hormonal status is important, which shows the premenopausal, perimenopausal, postmenopausal, and hormonal such as oral contraceptives and local systemic hormone replacement therapy will help in assessment of lower urinary tract. Previous pelvic surgery can affect lower urinary tract function. Anti-incontinence surgery, POPs repair, hysterectomy can contribute to a variety of urinary symptoms in women. Abdominal perineal resection can result in neurological injury that can affect the function of either the bladder or the sphincter, and back surgery can cause a variety of symptoms depending on the level of the affected spinal. Physical examination is the general appearance of the patient, including age, gait, stature, and fragility, and it can provide important information regarding performance status, neurological status, and other factors that may direct proper treatment planning. Abdominal examination with for incision, hernia, organomegaly, or bladder distension. Diary, we perform diary in men and women both, in which include the sphincter tone, presence of the hemorrhage, and rectal masses. In female, diary can facilitate assessment of rectovaginal septum, demonstration of rectocele. We are facilitating anterior pressure, anal sphincter tone, which is the reflection of the function of S2 and S4 spinal, and particularly important in urologic patient with the pelvic floor dysfunction. Patients are asked to voluntarily tighten the pelvic floor and attempting to stop the flow of urine midstream. Laxity is the rectal sphincter tone may suggest a possible neurological defect, and also may be due to the patient's lack of understanding regarding how to voluntarily control the specific muscle groups necessary for contraction. In pelvic examination of the woman, the external genitalia, urethral matrix size, location, lesion, prolapse, urethra, tenderness, scarring, masses, the bladder fullness, vaginal examination of the estrogen effect, general appearance, discharge, cervix, uterus, anal and perineum examination is compulsory. Physical examination in men it pertains to voiding function, also should include evaluation of the penis for metal stenosis, and particularly in the post-prostatectomy patient. Visible urinary leakage with cuffing and straining are seen. Examination for leakage is ideally performed with the patient in the standing position. On lying position, the abdomen to feel for any masses, and especially for the distended bladder and hernia. The external genital to examine for the foreskin, external urethral matrix, as some men may be suffering with overflow incontinence resulting from a stenosis of the external urethral matrix or a severe phimosis. Prostate should be examined via DRE to feel the size and the consistency, as well as asking the patient to perform a pelvic squeeze to assess the strength of the pelvic floor. On physical examination, the anal canal and lower rectum to feel for anal tone and sensation and to assess rectal emptying. Lower limb neurological examination to see the reflections, strength and sensations. Cuff test is also compulsory to see the patient to cuff. If there is any leakage, then ask the patient to stand and to cuff again to check for the stress in incontinence. So next is the bladder diary, which is a vital investigation tool, and it provides the objective information of the number of episodes that patient passing urine during the day and night 24 hours time. The average and maximum voided volume and hence bladder capacity, the type and amount of fluid being drunk, and the assessment of nocturnal polyuria and whether or not there is any urgency. Mostly 3 days bladder diarrhea is offered. In some studies, 7 days bladder diarrhea is also mentioned. This is the
Other things are also included in bladder diary are the episodes of incontinence, use of pads. That is also important. Difference between frequency volume chart and bladder diary is that in frequency volume chart you see the volume of urine passed and frequency, and in bladder diary you see all these things: intake, output, frequency of urination, episodes of incontinence, use of pads. So these all are included in bladder diary. So this is the difference in between these two: frequency volume chart and bladder diary.
Okay.
Another thing is maturation time chart. In that you only see the time of maturation. So these three things are done to see the maturation and
Different
frequency.
diaries. So this is the European Union bladder diary of urology. It shows the date, mention the date and time of the woke up and time went to bed. It is the how much you drink, the volume and type of the amount you drink and amount of urine you pass. There is the option you feel any strong urge or to urinate and any urine leakage seen. It's 24 hours bladder diary, mostly for 3 days. Next is for uroflowmetry is a simple diagnostic screening procedure used to calculate the flow rate of urine over the time. The test is non-invasive and may be used to assess bladder and sphincter function. In person with urinary tract obstruction, this pattern of flow is altered and increased and decreased more gradually. Uroflowmetry is performed by having a person urinate into a special funnel that is connected to a measuring instrument. The measuring instrument calculates the amount of urine, rate of flow in second, and length of time until completion of the void. The information is converted into a graph and interpreted by a doctor. The information helps evaluate function of the urinary tract and help determine if there is any obstruction of normal outflow urine. So before the procedure, your doctor will explain the procedure, how to perform, and the opportunity to ask any question that you might have about the procedure. Generally, no prior preparation such as fasting or sedation is required. You may be instructed to drink about 4 glasses of water and several hours before the test is performed to ensure that your bladder is full. Notify your doctor for all medications like diuretics and herbal supplement that you are using. Based on your medical condition, your doctor may require other specific preparations. So this one is the flow transducer in which a patient passes urine, and this stick shows that it should be straight, and height is also depend on the Uroflowmetry. And this is the flow recorder in which in a graphic reporting. So reason for the procedure is that it is a quick and simple diagnostic screening test that provides feedback about the health of the urinary tract and commonly performed to determine if there is obstruction to normal urine flow. Medical condition can alter this effect, and this is benign prostatic hypertrophy, cancer of the prostate or bladder tumors, urinary incontinence, blockage, neurogenic bladder dysfunction, and frequent urinary UTIs. The risk factor are that is a non-invasive procedure and it is safe for most persons. And test is usually done in privacy to ensure that the person while in a natural setting. Such a factor or condition may interfere with the accuracy of uroflowmetry. These factors include, but are not limited to the following: that is, training with urination, body movement during urination, and certain medication that affect the bladder and sphincter muscle tone, like the alpha blockers and the diuretics. So this one is the chart of the UFM, in which the x-axis is the time of the flow and y is the flow rate ml per second. The bell icon blue shows that is the maximum urine voided, and the peak it shows the how maximum it void per second. This one is a flowmetry of the patient, in which it is start delayed after the 2.5 second, and maximum flow rate is about 23 ml per second. Time to maximum flow is 3.5, and average flow rate is 10.6 centimeter. These are the different three types of the UFM, in which the red line shows the normal flow of the micturition, and the dash sign shows the obstructed bladder outflow, and the dot sign shows the urethral strictures. This one is the UFM of a patient with hypertonic neurogenic bladder, and which shows the poor flow with abdominal straining. These are the abdominal straining, which shows here is about 11.3 seconds. This is the poor flow with prolonged widening, and this is the intermittent poor flow with continuous leakage. This started with 2.7 second urine pass, and it is about less than 5 ml per second, and is mostly occurring in the spinal NG. This UFM is for patient with poor flow due to BPH. It started after 1.8 second, and the maximum flow is about 8.5 ml per second. So this is the reasonably good flow in a patient of very large prostate size. The maximum flow rate is 14.8, and it make a bell-like icon. This is the poor flow prolonged widening time, and it's mostly in a bladder outflow obstruction. The urine started at 0.7 ml per second, and its maximum is 5.7 flow. So maximum flow rate, if less than 10 ml per second, the percentage of obstruction is greater than 90%. If the flow rate is 10 to 14 ml per second, the percentage of obstruction is 76. If it is greater than 15 ml, there is a less risk of obstruction, about 30%. The post-void residual volume is the urine left in the bladder after routine voiding is termed the post-void residual volume. This is a simple test, and which can be performed via in and out catheterization or the ultrasound, which evaluate the bladder's emptying ability and can be helped in the diagnosis. The clinician considering a patient with the stress urinary incontinence should assess the post-voidal volume to evaluate the bladder emptying, and because patient with elevated post-voidal volume pre-operatively or at increased risk for developing voiding difficulty post-operatively. The Agency of Healthcare Research and Quality suggests that the post-void less than 50 ml represent adequate emptying, and greater than 200 ml represent inadequate emptying. Thank you.